Mike Gibson, Steve Nissen coming to you live from ACC 23. Steve, I think this is really one of the highlights of the meeting, the Clear Outcomes study. Talk to us about it.
Well, we started this trial in 2016. It's been a very long haul, studying bempedoic acid in a very difficult group of patients. These are patients that could not tolerate statins or are unwilling to take statins. And bempedoic acid is a drug. It's a prodrug. It's not active when taken orally, but it gets taken up by the liver, it gets activated in the liver, and then it works along the same pathway as HMG-CoA reductase inhibitors, the enzyme inhibited by statins. It lowers LDL cholesterol, it lowers CRP, and was approved to lower LDL cholesterol, but there's not been any information about whether it actually lowers cardiovascular morbidity.
And Steve, it's a prodrug, metabolizes, say, in the liver, but not out in the periphery, so it doesn't really cause muscle problems.
Yeah, and in the lead up to the trial, we knew that it was not causing muscle problems during its development, and we expected we would be able to give the drug to these statin intolerant patients, most of whom had, intolerable muscle symptoms, and that they would tolerate the drug.
And there are a lot of women out there who are statin intolerant, and one of the amazing things about your study is nearly half the participants were women.
Indeed, we had 48% women. We also made every effort to have a diverse population. It's one of the very few trials that have almost equal number of men and women.
So how many patients and what did you find?
We enrolled 13,970 patients at 1,250 sites in 32 countries. The principal findings were that LDL cholesterol at the 6-month mark, which is where we measured it, was reduced about 22%. CRP was also reduced about 22%. This drug has very potent anti-inflammatory effects. For the primary endpoint, which was 4-component MACE, cardiovascular death, MI, stroke, or coronary revascularization, the hazard ratio was 0.87. The number needed to treat was 63, and it was highly statistically significant. Now, we tested in a hierarchical fashion. So having succeeded on the first endpoint, we were able to go to the second, which was 3-component MACE, no coronary revascularization included, just death, stroke, MI. And there the hazard ratio was 0.85. I would point out that that's identical to what the PCSK9 inhibitors achieved. Highly statistically significant. We then moved to the next endpoint, which was fatal and non-fatal MI, and the hazard ratio was 0.77. It's a 23% reduction, also highly significant. And we then moved to the 4th endpoint in the hierarchy, coronary revascularization, and the hazard ratio was 0.81, 19% reduction, and also highly statistically significant. The next endpoint was fatal and non-fatal stroke. The hazard ratio was 0.85, but there were not enough strokes to reach statistical significance, and so we stopped testing at that point. We did, of course, also report on mortality. There was no effect, virtually identical to placebo, on cardiovascular death and all-cause mortality. I would point out in the last 15 years, almost every therapy, LDL lowering therapy particularly, did not have any effect on cardiovascular death. We've gotten too good at treating these patients. We have all kinds of other interventions, and they, in a relatively short-term period of time, they really don't die of the disease. That's a good thing, but it also means that our studies don't achieve a benefit on cardiovascular death.
And some people also got put on a PCSK9 inhibitor, which kind of diluted the effect.
They did indeed. The difference between the placebo and the bempedoic acid group narrowed progressively during the trial, so that toward the end of the trial, the difference was very modest. There was a lot of drop-in the placebo arm, as you would expect, and we allowed it because we felt it was the appropriate thing to do ethically. I do want to say one more thing about the ethics here, because there are people who believe that statin intolerance is the nocebo effect. We made patients sign a statement that said, I understand that statins reduce the risk of heart attack, stroke, and death, but I am unwilling to take these drugs. The adverse effects have made it impossible for me to take them. They had to sign a really rigorous statement that they understood the benefits of statins but would not take the drugs. And I'm very proud of the fact that we did that, because it means that we have a population that really could not be treated with statins.
Yes. And as a trialist, yes, we talk about relative risk reduction. I'm more of an absolute risk reduction person.
Yeah.
Having a 1.6% absolute risk reduction, only needing 63 people to prevent one of those events. I think that's persuasive data, particularly when it comes to cost.
It is, and many people like to extrapolate to the 5-year number needed to treat, and I didn't do that, but it's going to be under 50.
Yes.
So that's a pretty good good result, and particularly when you consider. Let me say one more thing: we had complete follow-up data in 95.3% of patients, and vital status in 99.4% of patients. In the middle of the pandemic, we included, by the way, in sites in the Ukraine, but we did have to truncate the data after the war started in February of 2022.
Yeah. Well, the amazing thing in one of my trials is Ukraine had complete follow-up, and not other countries.
Yeah.
Steve, congratulations.
Thank you so
Thanks for
much.
joining us today.
Yeah.
Thanks to all of you for joining us here live from ACC 23.